Hello, everyone. Just to give a brief introduction about myself, I am currently an ophthalmic scribe who, like you, is working on becoming a COA, or Certified Ophthalmic Assistant, through the International Joint Commission on Allied Health Personnel in Ophthalmology. As we know, the eye is a very complex structure despite its small size, and the text for this certification can be difficult to get through. I personally found myself disappointed at the lack of a lecture option, so I decided to make some myself as I work through this journey with all of you. I will be working with the Ophthalmic Assistant 11th edition by Harold A. Stein, Raymond M. Stein, Melvin I. Freeman, and Rebecca L. Stein, so all of this is thanks to them. We will be starting with the anatomy of the eye. If you currently work in a clinic, you may be familiar with much of this segment. However, this section is an imperative one as it will help you form basic foundations upon which the rest of this text are based. Many diagnoses are derived from anatomic terminology, so it is crucial to understand this information in order to better understand your patients and their conditions. Even if you have a good understanding of anatomy through clinical experience, I implore you to listen and build your knowledge further. Although we commonly refer to the eye as a globe, it isn't really a true sphere. Instead, it's composed of two spheres with different radii, one set into the other. The anterior or front sphere is the smaller and more curved of the two, called the cornea. You may have heard this referred to as the window of the eye. That's because it's completely transparent. It's more curved and sets into the posterior or back sphere like a watch glass into a watch. The posterior sphere is a white, opaque, fibrous shell called the sclera. The cornea and sclera are relatively non-distensible or unable to be stretched structures that encase the eye and form a protective covering for the delicate structures within. We'll go more into detail on these structures later in the lecture. The eye itself measures approximately 24 millimeters in all its main diameters in a normal adult. So we're going to start off simple with some surface anatomy today. The eye itself is covered externally by the eyelids, which are movable folds that protect the eye from injury and excessive light. The lids serve to swab the eye and spread a film of tears over the cornea, preventing evaporation from the surface of the eye. The upper eyelid extends to the eyebrow, which separates it from the forehead, whereas the lower lid usually passes into the skin of the cheek without any line of demarcation. The upper lid is more mobile than the lower and covers about 1 millimeter of the cornea when open. The muscle that elevates the lid, the levator palpebrae superioris, is always active, contracting to keep the lid open. This muscle relaxes when we sleep. The lower lid lies at the lower border of the cornea when open and rises slightly when it's shut. Normally, when the eyes are open, a triangular space is visible on either side of the cornea. These spaces are called canthi and are formed by the junction of the upper and lower lids. The medial canthus is closer to the nasal bridge, whereas the lateral canthus is closer to the temple. Most eyes are practically the same size. So what do we mean when we refer to eyes as being big or small? When we say this, we're referring to the portion of the eyes visible on external examination, which itself depends on the size and shape of the palpebral fissure. When the eyes are open, the palpebral fissures measure about 30 millimeters in width and 15 millimeters in height. The medial fissure contains two fleshy mounds. The deeper is called the plica semilunaris, and the more superficial is called the caruncle. The caruncle is modified skin that contains sweat and oil glands and occasionally fine cilia or hairs. In Asian persons, a fold of skin extends from the upper lid to the lower and covers the medial fissure, creating a monolid. The free margin of each lid is about 2 millimeters thick and has two borders, the anterior and posterior. From the anterior border rises the lashes. Upper eyelashes are longer and more numerous than lower lashes and tend to curl upward. The lashes are longest and curliest in childhood. The posterior border is sharp and sits tightly against the front surface of the globe. When we depress the lower lid, we can see the thin gray line that separates the two borders of the lid. This gray line is used in many surgical procedures to split the upper and lower lids into two portions. Also visible on both lids are the tiny openings that are the orifices of the sweat and oil-secreting glands. The largest oil-secreting glands are the meibomian glands, which are embedded into the tarsus, or the posterior connective tissue substance of the lids. The lacrimal gland is located above and lateral to the globe. This gland produces tears which travel through the ducts and empty onto the conjunctival surface. On the medial aspect of the lower lid, where the lashes end, is a small papilla. At the apex of this papilla is a tiny opening called the punctum, which leads via a small canal through the lower lid to the lacrimal sac. The lacrimal sac eventually drains into the nose. Tears are carried to the punctum by the pumping action of the lids, and there they are drained from the eye via tiny channels. A similar but smaller opening is found in the upper lid almost directly above it. The punctum cannot normally be seen by looking directly at the eye. It can only be seen by depressing the lower lid or everting the upper lid. The muscle underlying the eyelid skin is the orbicularis oculi, which is roughly circular. When this muscle contracts, it closes the eye. The portions of the eye that are normally visible in the palpebral fissures are the cornea and sclera. Because the cornea is transparent, we see the iris and pupil upon looking at it. The sclera forms the white of the eye and is covered by a mucous membrane called the conjunctiva. And again, we'll get back to the cornea and sclera later. We will definitely go more in depth on that. The conjunctiva extends from the junction of the cornea and sclera and terminates at the inner portion of the lid margin. The bulbar conjunctiva covers the eye itself, whereas the palpebral conjunctiva lines the inner surface of the lids. The junctional bay where these two meet is called the fornix, which can easily be viewed by depressing the lower lid. The conjunctiva serves many roles. One of these is to defend and repair the cornea in the event of scratches, wounds, or infections. The almost invisible blood vessels dilate and leak nutrients, antibodies, and leukocytes into the tears that then wash over the corneal surface. The conjunctiva also secretes mucus and oil, both of which help to keep the cornea moist and clean and to reduce friction when the lids blink. The conjunctival mucus film over the ocular surface catches microorganisms. This mucus net then condenses into a ball and is carried into the nasal canthus, where it then dries and rolls onto the skin. The conjunctiva also helps to resurface the cornea with epithelial cells if the entire corneal surface is scraped or burned. Under the conjunctiva is a fibrous layer that overlies the sclera and rectus muscle. This is a surgical landmark called Tenon's capsule. The tear film is composed of 3 layers. The outermost consists of a lipid or fatty layer, mostly cholesterol ethers, and is extremely thin. This layer is secreted by the meibomian glands and acts to prevent evaporation of its underlying aqueous layer. The central layer is chiefly aqueous with some dissolved salts as well as glucose, urea, proteins, and lysozyme. This layer is secreted by the lacrimal glands. The third layer is a very thin mucus layer lying over the surface of the conjunctiva and cornea. This layer is secreted by specific cells of the conjunctiva called goblet cells and is important in the stability of the tear film. Tear film abnormalities may arise in association with a number of clinical problems in older adults and in particular problems related to contact lenses. The precorneal tear film layer serves several functions. It forms a smooth refractive surface on the epithelium, maintains a moist environment for the epithelium, and carries oxygen to the eye. I'd like to thank you all for watching. I've never done anything like this before, and I'm a little bit sick, so I apologize if my words weren't as clear as I tried to make them. Hopefully next time I record one of these, I will be a little bit less stuffy, a little bit clearer. This is a learning experience for me in 2 different senses, both in that I am learning how to make videos like this and that I am learning alongside you to hopefully attain that COA. I know this is a very rough process and that there isn't much available to us online, so I was really hoping to kind of supplement. That being said, if there is anything you think I could have done differently, done better, if there is anything you would like to be expanded upon, or just any suggestions or questions you might have, please feel free to leave them for me. I am more than happy to do what I can to make this as helpful as possible to everybody who is watching. So today we just really covered surface anatomy and the tear film, but we will be moving on to deeper anatomy the next time I make a video. Um, and best of luck to everybody who is studying, who is working for that COA. I see you guys. I am so proud of you. I know it's hard work, and we are all just doing the best we can out here. So once again, thank you so much for sitting through this with me, for learning with me, and just best of luck to everybody. Thank you.